السلام عليكم. الشكر الجزيل للأخ دكتور محمود زريق على الدعوة الكريمة، والأخوة في المملكة الأردنية الهاشمية لدعوتهم لحضور هذا المؤتمر. This session 3, will talk about the CTO, and as we know that the CTO is one of the challenges in coronary intervention, and we have a newly established methods, advances, antegrade, retrograde, microcatheters, and so on for the treatment of CTO. We have two distinguished speakers to talk about the CTO, Dr. Raed Alawaisheh, three distinguished speakers, Raed Alawaisheh from Jordan, and he is well-known interventional cardiologist, and he is using from the past many years ago to talk, to use the antegrade and retrograde approach for the CTO. And also we have one of the distinguished brothers from the Hawk Cardiac Center in Iraq, Dr. Shawkat Miro. He is the leader of CTO group in Iraq, and he has also his way in treatment of CTO. Also, Dr. Amr Alkarmi from Jordan. He will talk about the high-risk PCI in this session and iVAC. Is Dr. Raed Alawaisheh present here or not? Or shall we start with Dr. Shawkat first? Okay, Dr. Shawkat, the floor for you. أرحب بزملائي الأعزاء الإخوان دكتور نائل الشوبكي ودكتور حسين عميرات، ما موجود يمكن دكتور ساجد من فلسطين العزيزة، والدكتور حاتم حسن من مصر الشقيقة. أهلا وسهلا بهم. دكتور شوكت, the floor for you. Sorry.
Assalamu alaikum. Thank you, Mr. Chairman. Thank you for the organizing committee for kind invitation. Dr. Raed, sorry, we started before you. Okay. So I'm going to talk about Ostial CTOs, whether to start retrograde or antegrade approach. I have nothing to disclose. And we know by definition that any lesion within 3 millimeters from the ostium is considered as ostial disease and including occlusions. And it is very well known that ostial CTOs, they are more challenging than other parts of the arteries when they are occluded. And there are several studies are available that describe these type of CTOs. And the latest publication, it was in 2023 by the group of Manos Brilakis. They studied more than 8,700 patients, and in their conclusion, they found that ostial occlusion, they constitute about 12% of all CTOs, and in another earlier studies by the group of Dimitri, they found it is around 15 to 16%, and they found that most of those patients had ostial CTOs. Usually they had a higher JCTO score, and ostial CTO PCI had lower technical and procedural success when compared with non-ostial CTOs. CTO PCI of ostial occlusions is usually associated with frequent need for retrograde crossing, and there is a higher incidence for death, stroke, and longer procedure time, as well as higher radiation dose. So I'm just will show you 2 of my patients that we recently did. This is one of the patients that you see there is an ostial LAD occlusion, and the other one is an ostial CERC CTO, which is covered by a stent from left main to the LAD. So in the first case example, he was a 65 years old, gentleman, he had angina for 3 to 5 years back, and recently was admitted with unstable angina. He had the common risk factors for cardiovascular disease. He had normal ECG and echo, and there was a high-risk positive treadmill test. Angiography was performed, and this is the caudal shoot. If you appreciate, there is a very small at the ostium of the LAD, there is a small opacification, and this is the cranial shoot. If you appreciate that there is a good retrograde collateral filling from the marginal branches that supplies the distal LAD, and this is the spider. If you appreciate the ostium, it is occluded with a tapered cap, and this is the RCA shoot. There are multiple septal collaterals and epicardial collaterals from the RV branch that also supplies the distal LAD. So how to approach these patients? As we know, we have the global crossing algorithm to approach any CTO, and usually it starts the first step with the proximal cap ambiguity, whether the proximal cap is clear or not. In most of the times when we have ostial CTOs, most of the times the proximal cap is ambiguous, but in this patient it was relatively clear, so we decided to go with an antegrade approach. If we fail, we have good septal collaterals from the right coronary artery to come retrograde D. But generally, just we mentioned earlier that most of the ostial CTOs, there is a higher chance to need retrograde approach. So this is from right radial approach 6-frame system. We introduced the workhorse wire, the cyan blue, just to engage the cap with a Caravel microcatheter. Just we engaged the proximal cap, and then we changed the wire in the fashion of antegrade wire escalation, and I shifted directly to Gaia third. And this is the advancement of the Gaia third. If you see with the same guide injection, the wire is dancing very nicely with the artery, but it is clearly outside the lumen, whether it is sub-intimal or subadventitial. There was a bend is there. I just pulled the wire back, did the redirection, and again we have an injection. It seems the wire now is following the course of the artery, and just advance the microcatheter and the steps of pre-dilatation, deploying 2 stents, post-dilatation, and that is the final result. So most of the times, ostial CTOs, they are not as easily phased. This case, if we calculated the JCTO score, there was calcification, multiple branches, long occlusion. The JCTO score was high, but we were able to do it antegradely. The second case, actually, this case had a very long story. He is a 65 years old male patient who referred for circumflex CTO PCI. The patient in 2012 had inferior ischemia. At that time, they did PCI RCA. 3 years later, acute coronary syndrome, underwent CABG for in-stent restenosis, LAD circ disease. In 2017, he presented again with SVG to RCA occlusion, but at that time, they did viability and they concluded that the RCA territories are not viable. So the patient was kept on medical therapy. In 2019, he presented with Lima occlusion, SVG occlusion. They tried CTO circ, but they failed. So they did PCI left main to LAD under imaging guidance. And they left the circ for medical therapy, and the patient was very symptomatic despite receiving multi-anti-anginal drugs. His echo was ejection fraction around 40, and then they referred the patient to me for any possibility of circ ostial CTO. And as we mentioned, that the ostium of the circuit is covered by a stent. So if you notice from the angio that the ostial circuit is not clear where it is arising, and distal circuit is retrogradely filled from collaterals, most probably by the diagonal. This is cranial shot, and if you appreciate, you will see collateral filling to the RCA, PLA, and PDA. So the point here in this patient, the challenging that the patient is living on that LAD. So if anything happens to the LAD, the patient will collapse on table. And the problem in these ostial CTOs, it is the ostium, it was clearly ambiguous. There is no evidence of any cap, and it is covered by the stent. So again, how to approach? We have the algorithm. Here the cap was ambiguous, so we have either to do iVAC in the side branch to clarify and do puncture under iVAC guidance, but at that time the iVAC was not available in the cath lab, or move the cap techniques, which is very risky. We cannot do it in the left main stem. The other option is to go directly for the retrograde option, and the only supplying collateral to the circuit was from the diagonal. So this is the 7-French system, and I put the first step, a safety wire in the LAD, if you appreciate here, because if anything happens, I have to just stent that LAD to save the life of the patient. This is a microcatheter in the diagonal, and tip injection, it shows there is some connection with the marginal branch of the circumflex. So I took a Sion black wire, and with some very sharp, small 1 millimeter bend, I tried with the gentle manipulation, and I was able to advance the Sion black into the marginal branch of the CER. And we did a confirmation shot that it shows that my wire is in the correct position, and it followed by microcatheter. This is the caravel 150 centimeters, and injection from the caravel to see the distal cap. It is a relatively short occlusion, so I said I will try to do directly puncture from the retrograde into the left main stem. This is the this is the Gaia and Gaia third, and if you appreciate with gentle manipulation, very simply, my wire just jumped into the left main stem, and I was able to cross into the aorta. The point that here I tried to advance the microcatheter retrogradely just to follow into the aorta, then multiple options are there, but unluckily with the pushing microcatheter, I lost my wire. So I said, okay, I will, since my Gaia third went easily, I will try with the Gladius, and again, I was lucky probably. The Gladius just followed the path of the Gaia third, and now it is in the aorta. So here we have multiple options, either to insert another sheath guide and try to do a ping pong technique, but I tried to redirect my wire into the same guide, and if you just see it, now it will jump into the same guide. It is a 7-French system. And then I put another microcatheter beside the caravel in the same guide, and I did a tip-in, now the retrograde wire in another antegrade microcatheter, and I tried, this is the Corsair Pro microcatheter coming antegradely over the same wire, and now if you just see on the right side of the screen, a microcatheter with gentle rotation and taking its time, it is crossing the occlusion. If you see, now we have the retrograde microcatheter and antegrade microcatheter, they are kissing each other. And I pulled my retrograde microcatheter, did an injection, there is no leakage, no perforation, and changed the procedure to antegrade fashion. Again, some predilatations, and deploying the stent from left main to circ, then recross, applying DCB to the LAD, and post-dilatation, final port, and kissing port. This is the final angio. TIMI3 flow restores with no complications. So the take-home message, careful planning before CTO PCI is mandatory. And as we mentioned, there is a very high incidence of ostial CTOs during CTO PCI. Ostial CTOs, they are challenging and they carry higher risk than non-ostial CTOs in terms of MACE. Ostial CTOs, mostly you need to have a retrograde approach ready. Imaging, intracoronary imaging is especially of value in these situations and make it more feasible. Thank you very much.
Nice cases. Can we do the discussion after, because they are interesting cases, so we'll take them one by one. So, as usual, it's a very nice case, but I have many comments, especially for the second case. The second case, you need to, when you go back with the wire to penetrate the distal cap and you return back to the left main, you know that you should be very cautious because this can cause dissection in the left main, and you should, usually the recommendation is to do it with under iVAC guided
yes.
re-penetration and re-entrance to the left main. You were lucky here in this case and you went there, so no argue with success, but this is the usual recommendation.
Most of the time is lucky.
He's most of the time lucky, very lucky. So the second point,
I think you have to make your luck.
yes. So I expect next time when we see this is the recommendation, because people here, they want to hear about CTO, and usually when we go back to the left main from retrograde, we need under iVAC guided penetration. It's not just penetrate, because the risk of dissection and perforation and even going to the aorta immediately is there.
Yes, actually there was one point here. I said, unluckily at that time in that cath lab, iVAC was not available, but there was left main which was very well deployed previously under iVAC guidance in the left main to LAD. So that made some enthusiasm to penetrate that stent under good fluoroscopy and stent both. I did several injections, views to see whether I penetrated the stent or I am going behind the stent. So that made some point and courage to do it without any intracoronary imaging.
Second point, the length of the wire. Use the Gladius Mongo 3?
Yes.
GM 3?
Yes, it was Gladius Mongo.
And the length of the wire, do you have, what length do you have in your eye?
No, it was the standard, not the 300 centimeter.
So
but I came,
I
just did tip in the guide and advance the guide over that one and then pull it back because it cannot go the whole way.
Exactly. So the
Yes.
microcatheter, you did not show us that the microcatheter inside the catheter you did the tip in.
Yes.
That's it.
Yes.
Because it's not showing.
No, I show that.
You showed that the tip
Yes.
is down.
No,
Now
at the
two
guide,
wires kissing each other.
after it went into the guide,
Yes.
and I showed the shot of the guide, the wire went into the second.
Yes.
So two microcatheters in the same 7-French system, one Caravelle and one Corsair Pro.
Exactly. This is another point also for CTO. Usually when we do this technique, we go with 80 French guide catheter, not 7 French, because sometimes you need to trap the wire.
Yes.
So we need to trap, you need balloon also. So the 7 French guide catheter will not take the 3 tools together. So 80 French is the recommendation. Another recommendation, you do the tip in inside the guide catheter. This is not an easy one. You need really, sometimes if you fail, what you will do?
I think you just keep the microcatheter in the outer curve of the guide, and at the aorta, usually the wire will follow and it goes very easily. I never faced difficulty in doing catheter tip-in. Never. I think it is not so difficult, in my opinion.
I think you go with 5 French or 5 French catheter inside the catheter and we go with the wire there.
Here, yes, it is not possible here. Yes. Yeah.
When you have interference, it's possible.
Yeah.
So this is the point. This is lots of technical there. Your cases are very nice, but also we want to deliver messages for everyone hearing about CTO. That's why when we talk about CTO, we need many things to make the step before you do the step. You account the next step.
Yes.
So the interference will help. Having the length of the wire is very important, and be always safe doing CTO when penetration going back to the left main. Have anybody has any comments, please?
Nice cases. The first case, retrograde, antegrade to ostial lesion. We have no comment in the first case. Second case, the comment, as Dr. Raed said, the penetration to left main.
The first case, by the way, the first case, you did it by Corsair.
No, it was Caravel. The first one, yes.
Caravel, but any of them. Allow for me. This is also another luck, because when you go with Gayatri and with penetration, you need support.
Yes.
And this doesn't. It will slip easily to the RCA. Why I'm saying this? Because the people here, they want to hear about how to do CTO. Maybe the proper thing was to do is to go with the wire and to go with the double lumen microcatheter.
Yes.
So first you get two things. To protect the side branch, and the second thing, which is very important, is when you have the support with the double lumen microcatheter, and when it flip back, it will not flip back, it will even get more support.
Sure. But I don't know how is the situation in Jordan, but in Iraq you don't have such luxury if using multiple microcatheters. So usually I try with simple steps. If you are able to do it, yes.
I'm not far away from you.
We have multiple options, yes.
Right.
Okay, Doctor.
So thanks for the nice cases.
Dr. Adnan, comment?
Thanks for the nice cases, well presented. My question to you, Raed, and the rest of the panel. When you penetrate the left main, you're worried about either penetration of the left main or dissection of the left main. Would regular angiography be helpful in these? I mean, how would IVAS help you more in a penetration of the left main? Wouldn't you see dye stain?
Yes. Actually, go.
Okay.
Please.
Actually, what he meant to write, I think he was saying that when you try to penetrate retrograde, probably the wire will go subintimally behind the left main, and to be very dangerous if you penetrate subintimally into the aorta. So you are making another channel, and then you may lose the patient. So the recommendation is just to Raed mentioned, you try direct visualization of wire, and you do penetration. For example, if IVAS was available, just to put IVAS there, you would be able to see the shadow of the wire, and you try to keep your wire within the intimal rather than going behind the stent. What I did actually, there was a stent boost at that cath lab. I tried to visualize the stent under the stent boost and try to puncture the stent. I was trying to follow into the stent, and that was the idea that helped me to keep my wire inside rather than going outside.
Dr. Shawkat, I think most of these cases you do, or you did most of the cases of CTO in a private center. Is it?
Yes.
Or not? Yes. I think it is a lot of cost. What about the cost effectiveness or cost benefit? What was need to be mentioned by Dr. Hatem is that if you go to the CTO in a CERC, Ostial, proximal CERC, deceased visual, and you, the patient pay a lot of money, and the recurrence rate and the prognosis and the fate of the patient with CTO, do you have some study to follow those patients for 2 years, 3 years? With control angio, yes?
My patients, actually, I do these patients in different cath labs and traveling some regions. So I will fit sometimes this patient with materials that is available in the cath lab. Although the safety is the priority, but sometimes you have to do it. I have follow-up of around 500 patients, and I will try probably to publish it in this year and to see, because locally in Middle East we have no registry.
اتفق انت ورائد حتى
Yeah,
شلون
we will
نسويها.
find out.
Hopefully.
Can we go to the next? Yes, please.
Okay.
Can you present the next one?
Thank you very much, Dr. Shawkat,
Thank
for
you.
your nice
Thank you, Mr.
presentation. We should go to the next speaker.
Yeah, okay.
دكتور رائد العواشي انترفنشنال كارديولوجيست جوردن.
Can I have my slides, please? Okay. Thank you very much. Most welcome, everybody. My task today is to talk about the CTO. Where are we in 2024 in in this meeting? Actually, I start from the beginning, where really we still have myths. I have seen this in the practice everywhere, that we still have myths that CTOs are rare findings. Actually, they are not, and I'll show you the evidence behind this. The CTO rarely cause ischemia due to collaterals, and this is very common actually in the practice, that you have collaterals, so no need to open this vessel. This is another myth. And the medical therapy is fine. This is another myth. And the CTO do not affect mortality, and this is another myth. And the CTO have poor success rate, and this is another myth. Why? Because we are now in 2024. Is it rare? Since long time we know that in the registries for patients with coronary artery disease, in the registries, 15 to 30% of the patients, they have CTO. So 1/3 of the patients sometimes you have in some registries. In the Canadian registry here, you have it in 18% of the patients with coronary artery disease, they have CTO. So CTO is not uncommon. It is there, and we should face it. And actually, when the interventionist inside the cath lab sees the patient with CTO, he stops there, and the decision get different completely when you have just the stenosis from having CTO. In 2004, it should not. In 2024, it should not. In 2004, yes. But in 2024, actually, when you have a CTO, you should consider it same as a stenosis. The effect on the management, actually, of having CTO, you can see from this diagram that the patients, they left them for medical treatment in 44% of the patients, and patients, they went for CABG in 26%, and 30% to go PCI. Only they try to do of them a few percent of them, which is almost 10% of them, the interventions try to open them or to touch them, and the success rate is 70% in expert hands. This is in 2004 to 2014, but in 2024, actually, we have increased the success rate to 90%, and I will show you this. Okay, CTO rarely cause ischemia? No. You can see here that all patients actually who have CTO and filled by collateral, retrograde or antegrade collateral, they don't fill well. And this is by FFR and QFR evidence that we have almost the supply of the vessel from the collaterals reach only to 10%. So actually having collaterals refilling the CTO vessel, no, this is not enough, and ischemia is there, and evidenced by FFR and QFR. Okay, would having this CTO affecting the patients with angina? Definitely yes. When you have a patient with CTO, he has angina, and the favor of opening the vessel is really high. So yes, we are in favor of opening the CTO. But one of the attitudes also on the side, inside the cath lab, if you have CTO, don't just try to open it without planning. And planning comes from the indication. Is there indication or not? If I open this CTO, am I going to improve the patient's symptoms? improve exercise capacity, improve LV function, reduce the need for CABG, and improve survival. And this is what we will discuss. And the symptoms, very important to concentrate that the symptoms, it is not just angina. It may be angina, heart failure, fatigue, and very important point in 2024, again, to improve the LV function. LV function, it is not necessary to be global, maybe regional. And it is very, very important actually when we open a CTO to concentrate in that area. Would it improve by opening it or not? And the survival, which is very important issue, and the discussion actually is still open till this year. How about improving the survival? The survival, yes, it improved the tolerance of second MI or another MI. If the patient have CTO and develop MI, the double jeopardy effect of having two occluded vessels is really killing. And the complete revascularization issue, as you know, you need to do the intervention or the CABG for the patients to achieve full revascularization. If you did not achieve full revascularization, it means that you are doing something less than perfect. And also we will talk about the ischemia risk. Okay, so the patient selection. Yes, it's very important to have to select your patient. It is not any patient with CTO you go and open it. In the patient with if the patient has symptoms, yes, I need to consider opening that CTO, angina, heart failure, arrhythmia, and the chance of the procedure success should be counted very well, and the success for recanalization, improve the patient's symptoms. Is it going to improve it or not? And is it going to improve his prognosis or not? And the risk of recanalization, the safety is very important. Am I going to affect this patient's safety or not? So all of these things should be in the decision. And now in 2024, it is not only angina. You need, if you have a patient with MI, prior MI, you need to have viability tests. Viability test is mandatory. Even if having symptoms, the patient's having, yes, we need to have viability or not. Patients without MI, we need to document by an investigation that the patient really has ischemia, reversible ischemia, in a good amount of the muscles. And now the agreement almost about 7%, 5 to 10% of the muscle should have reversible ischemia. And how about giving the medication with CTO? We need by all the time to have in our consideration the complete revascularization. And to have this, always we start with the CTO. The studies from the beginning did not show that there is improvement in the survival. Every study have a drawback. Every study from the famous studies, the Excel, the Euro, and the Decision, which are the three famous studies for CTO, and showed that there is no improvement in the survival. Each one of them has drawback. Anyhow, we will not concentrate too much on the problem in the old studies. We will go to the new studies. From the Comet heart failure registry, you can see here, I will go to the conclusion immediately just to go to the analysis actually showed that the patient with ischemic cardiomyopathy in the presence of CTO, he has a worse long-term prognosis. So having CTO in a patient with ischemic cardiomyopathy increase the mortality. When you come to the opening the vessel, yes, it may improve the prediction of the recovery, especially in the area of the CTO. Now in 2024, many cardiologists, they depend on MRI actually to make their decision of doing CTO or not doing the CTO, and many parameters actually taken there, either regarding the thickness, the volume, the ischemia, and all of these parameters take in consideration. One of the most important one of them is the 7% myocardium improvement. The conclusion from this one that yes, the CTO affect the outcome, and having the proper patient with the proper findings, you go and open the CTO and improve the outcome, especially for the symptoms, and you may even change the prognosis. So my conclusion from this part that
the effect of reopening CTO in impaired LV, or what we call it reduced ejection fraction, is established now. The viability is very important. Symptom is, and the quality of life is the most important parameters that guide you to do the CTO, and also the outcome from this, really your patient get the most of the benefit from improving the symptoms. When we come to the studies, still maybe till now, we will never even be able to prove that the survival is improving by opening the CTO, in spite of having the significant increment in mortality when you have a patient with CTO. But till now, we can't prove by the studies, by the random control trials, we can't prove that the patient, when you open his CTO, you will improve the survival significantly. That's why this is reflected in the guidelines, either the European or the American guidelines. In the European guidelines, 2018, still till now, they are not updating it. The recommendation for opening a CTO is class 2A, with a level of evidence of B. So you should consider, that means that you should consider opening the CTO if you have symptoms and documented ischemia and the patient is not doing well on optimal medical treatment. How about the American guidelines? It is 2B, which means that they are not certain about opening the CTO will reflect on benefit. When we come to the European guidelines again, medical treatment first, and as I told you before and also in this registry, that how CTO reflect on the decision. How about the mortality? Told you that it is in favor of success. So if you have a CTO and try to open it, if it open yes, it is in favor of success, and the mortality even in favor of success. Why? Because of the concept of double jeopardy. When you have this patient, actually, I had this patient, and by the nuclear study, he had the area is infarcted, in the RCA area is infarcted, it's thinned out, but he's dependent on this one, and he has the lesions in the left system. When you have a total occlusion of the LAD, especially if it's proximal, and you have already the RCA is totally occluded, I think the outcome is really bad. And this is the concept behind the double jeopardy. And this is also confirmed by the CTO impact, that when you have a patient with CTO, you can see that if he had MI on top of CTO, what is the difference in mortality? It's very huge if you have a patient with CTO and developed acute MI. So this is by the another studies also to show the same. How about the other myth, which is the CTO have a poor success rate? This is this was before the poor success rate, because actually we don't have the right tools. It is not available everywhere, and also the experience is not there. That's why the recommendation nowadays for the last 2 decades, that for CTO to be a subspecialty of interventional cardiology. So interventional cardiology is a subspecialty of cardiology, and CTO is a subspecialty, and it needs 2 years training in most of the areas of recommendation. Why? Because there are many techniques actually, as you see in this slide, to do the CTO. You need many tools actually, and you need to be aware about them. You know them, all their criteria. The length, the width, the catheter capacity can take it or cannot take it. You have many wires actually to go there, and to know step by step how to go with the wire escalation, and to be very aware about the hybrid procedure of doing the antegrade and retrograde. This will increase the success rate, and this needs lots of training and lots of experience to be able to do it. This is, you have seen it for the ambiguous ostium, for example. Many things you need to be aware about. You need to do iVAC and to know how to read iVAC, and to know the techniques like the star technique, mini star technique, how to move the cab, and the dangers of doing this, and the dangers of each technique, the anchor technique, the retrograde, the antegrade.
the ADR, the RDR, the AFR, there are many things to say there actually of doing the CTO. And knowing all of this, actually, it is not comes from nothing. It is actually in this case, as you can see here, that the RCA is totally occluded and the length of the occlusion is too long. So you need the hybrid approach here where you go with the antegrade and retrograde. And as you can see here that we go with the RCA, and the RCA bifurcate actually here, and the crux you have the BLB and you have the BDA. You need to keep them, and this is what I did. Actually, I did ADR and RDR, the retrograde wire to the BLB and the antegrade wire to the RCA, and this is to keep the side branch and the two branches there, and this is the case, and confirmed by iVAC, and very successful result. OCT is good actually to use it. I will not talk about it. The hybrid actually now in 2024, because I'm short of time, now the success rate is reaching 90%, and the MAZE less than 3%, and the survival is around 70%, but the success rate is really more than 90%. Why? Because now we have the DS, we have the guide extension, we have the multiple microcatheters, either the single lumen or dual lumen, or even the triple lumen microcatheters, and we have the diamond lithotripsy instead even of the rota and the safety of it. We have iVAC, OCT, CT, all of these things, so that's why we have and more experience, and you have more success to reach to 90%. The dilemma is still there about the survival. Symptoms may be solved, but in the survival, you need to go here and find out if the patient has ischemic cardiomyopathy or he has CTO, medical treatment, electrical treatment, everything. And if the patient is still having chest pain, you may consider doing for him. If there is a prognostic value, you go with CABG. If there is no prognostic value, and still the patient is symptomatic, you may go for CTO PCI, and you can support this by the MRI. Now it is the MRI, cardiac MRI is the favorable one to make your decision. The length of the lesion is very important, as you can see here, to choose either ADR or wire escalation, and also distance are there. So these are to make the decision and how to go with which of which. This is now we are in the luxury of the drug-coated balloon, and this is a case where the ECTO was opened and managed by just doing the DS without using DS. It is just by using the DCB, and this is the result, as you can see here. So it's a good result, beautiful result in CTO by using just drug-coated balloons. And this is by iVAC, and I'm showing you here even how the DCB showed the good result. So my conclusion that the CTO are not infrequent. They are there, and opening them reduce the angina definitely, and the collaterals are not enough actually. And the attempt to CTO is really low between the intervention cardiologists. That's why this is reflected in sending the patients to surgery. In 2024, we have the tools, we have the experts, we have the centers where you can refer even the patients if you will not go for the training, and you have the success rate increment by using the hybrid technique to be more than 90%. So when you have a CTO, you should consider it as stenotic coronary artery disease. It is not CTO anymore. And the BCI CTO has not been shown on pragmatic value. And the BCI CTO can offer symptom relief, yes, and it should be performed by dedicated operator in dedicated place where you have everything. Safety is very important, and DS maybe is not always the solution, and DCB may be an alternative one. Thank you very much. I think I'm out of time. Thank you. I can't hear your voice. Can you open your mic, please?
Mic.
شغال؟
Yes. Go ahead, please. Now it is okay.
Okay.
Hello?
Yes.
Yeah. Thank you, Dr. Raed, for this excellent presentation about CTO. I have a practical question. When they refer to you a patient for cardiac cath pre-op for extra cardiac operation, and you find accidentally a CTO, you prefer to open this artery or leave the patient to do his surgery?
I did not grab your question.
He mean that
When you find a CTO for a patient who was referred for a cardiac cath pre-op evaluation for extra cardiac surgery, you prefer to open this artery or you leave the patient do his surgery? He is asymptomatic.
Definitely, I will send him for his surgery and not to do for him the CTO. Why? Because the CTO till now did not improve or did not prove itself as to improving the survival and prognosis. Depends on the operation that the patient will go to, the other non-cardiac operation. Most of the time, the non-cardiac operation is something should be done to the patient. So I will postpone doing the CTO after the patient finishing his operation.
Okay, another question, it is a technical question. When we have a perforation with pericardial effusion in CTO procedure, is it difficult to manage to stop the bleeding in per procedure?
Oh, the perforation of CTO operation, PCI, CTO PCI is one of the famous complications, or one of the important complications actually, is perforation. And the type of perforation. Is it a perforation at the site where you have the CTO? And this is really not that important. The important one really, if you have perf before or after, and especially if you have exit wire perforation. Exit wire perforation is very common. Why? Because we use stiff wires, and sometimes we go with the wires, we cross the lesion, and we penetrate the vessel distally. When you have perforation like this, how to manage a perforation in the vessel, in the lumen, or exit perforation, they are different. For exit perforation, we go with embolization, coil, fat, tether, sutures, whatever. You go and you send it there, and you block the exit. When you have the perforation in the lumen, you go with the cover stent, the inside TAMP technique, all the techniques that you go there.
Thank you very much, Dr.
Amr.
Dr. Raed. Any question from the panelists?
Amr, right?
Great presentation, right? But I think we always fail to mention that, as we mentioned, that CTO is very advanced. It's a subspecialty. But if you get an experienced operator, let's say, you started and tried off doing a CTO for 15, 20 minutes and failed and stopped, what's the mortality of that patient?
Mm-hmm. Actually, it is mentioned in the Canadian trial, in the Canadian registry, that yes, they have tried the CTO, and the failure actually increased the mortality in comparison to just leave the CTO alone without touching it. So the evidence is behind what you said, and that's why it is not good actually when you have CTO, as I mentioned here, that you have, yes, Mountain of Everest. Why are you climbing Mountain of Everest? Because it is there. This is very bad answer. No, it is there, you will not climb it. You should plan and you do the right attitude of really to find out, am I going to open it? Is it good for this patient to open it or not? Because if you try to open it and you failed, you increase the mortality of the patient. You are right.
Thank you very much, Dr. Raed. Because of the time, we should conclude that thank you very much, Dr. Raed, that the CTO is not improving survival till now, according to the big trial, auto trial. And the second thing is that you should never go to the CTO unless your cath lab is fully equipped with 2 tools, wires, graft stent, and so on. The third thing is that the experience is very essential. Thank you very much. We shift to the last speaker, Dr. Amr Alkarmi from Jordan. He will talk about the high-risk PCI and iVAC. The floor for you, Dr. Amr.
Thank you very much to have me. It's not only me in this case, it's a big team and big support team. It's not only support device, it's a support team. So I have to thank my partner, Dr. Ibrahim Jarrad, Mustashfa Al-Khaldi for the great support, and Ziad from Sunnah Al-Qarar. Now, I'm not going to go to technicality of this patient, but he's a 67-year-old hypertensive, diabetes, heavy smoker, you name it. He had a multi-vessel PCI in 2018 with 5 stents, I think, put in, and lost follow-up. He had normal LV at that time, and he had no review. He presented after the Corona era and with shortness of breath, and he's still smoking about 50 cigarettes a day, and he was in NYHA class 3 with ejection fraction of 30% at that time. He was on the full whack of heart failure medications. Then he was put on NOAC for a smoke in the LV, but no thrombus. In 2022, later on, he stopped all his medications. He's completely non-compliant, but with no improvement in his LV, his NYHA class 3, class 4, and he had a coronary angiogram done at that time, and he had the diffuse coronary artery disease. Some stents are open, some stents patent, some closed, new CTOs, whatever, you name it. Anyway, we continued the medical therapy on him, on and off his medications. He's not compliant. His ejection fraction eventually in February 2023 dropped to 15%. He was in NYHA class 3. He had a narrow complex on his ECG. ICD was offered. He refused. He had a moderate MR, and he went for a MIBI scan for viability, and it appeared to have some viability here and there. We discussed this case with our surgeon, and there was no target for revasc. It's completely diffuse distal disease. You'll see the pictures coming. So we had long discussion with the patient, and he was agreeable on a high risk PCI, but with ejection fraction between 12 to 15%. So we decided to go for the iVAC 2-liter support device. So it's an easy device. It's not like an Impella device. And you put it inside the LV, and you got bidirectional valve somewhere in that area. And it doesn't matter whether it's actually inside the LV, outside the LV, on the side of the aorta. It just, because it's a pulsatile, it's not like an Impella, it's a motor-based. So what happened, we'll talk about it later. And this is just replacing the device, and it's an 18 French, so you have to be really careful with this one. And this is how we place it. And this is just the technicality of the PCI. I'm not going to go through them, but he had a lot of stents and DCBs with good results. Total procedure is about 50 minutes. He tolerated well. We pulled the device at the end. And it's been now more than a year and a half. He's still coming to my clinic. He's currently NYHA class 2, despite he keeps stopping his medications. And he's still smoking 50 cigarettes a day. So I'm just going to mention about the iVAC system. So there are 4 main, let's say, technologies: the classical intra-aortic balloon pump, the short-term assistant devices, that's including the Impella, iVAC. You've got the bypass machine on the operation, and you've got the ECMO. The iVAC is it's a short-term circulatory system support. It's done percutaneously. and it's a pulsatile. So you connect it to the balloon pump, okay? And it gives you almost 2 liters of cardiac output on top of the existing cardiac output. So basically, after the LV systolic, whatever residual will just suck and throw it into the coronaries and into the rest system. So it consisted with a tip, bidirectional valve, the tube, and the membrane pump, which is about 40 millimeter, and this is the device where it's connected to the balloon pump. Okay. And it's activated by the helium, basically by the ECG wave or by the pressure wave, depends how you connect into your intra-aortic balloon pump. So the helium during the systole will suck the blood into the membrane, and during diastole, the helium will just throw it back into the same valve into the aorta. And this is just how the shift of the iVAC through this usage, and the longer the procedure, actually, you get better shift. And this is how the helium and how you get the wave of support. So that's without the support, that's with the support there. And the Japanese, as usual, they looked into this in very details, and they looked into the coronary flow during the usage of the iVAC compared to the balloon pump, and you look, it's a more prolonged and perfusion during the usage of the iVAC. And the Germans now, they use it much, much, much more in the mitral clip in poor LV, because it reduces the pulmonary capillary wedge pressure. So it's almost used in anybody with a mitral clip with ejection fraction less than 40. So this is the registry. So there's not head-to-head trials, okay? And this is how they started using the iVAC. So obviously not a lot, 174 patients, but it's a safe device. It's obviously you can see the patient criteria. It's high-risk patients you're talking about. And the iVAC gave 1.5 to 2 liters cardiac output, extra cardiac output during the procedure. And the selling point for this, I think, is the hemolysis compared to the impeller, because they reported no hemolysis. While the impeller, the larger the impeller you use, the more hemolysis you get. And you can't sell always on the kidney injury. But again, this is not randomized trial. This is head-to-head. It's just a comparison between 2 registries. And this is, again, not randomized trial, but this is the iVAC 2 liter to impeller. And it gives almost the same support of the impeller CP, but the playing point in Europe was, or the selling point in Europe was the cost effectiveness. Even here, it's mostly around 40% of the impeller price. So it's good for probably support in elective cases. In acute cases, probably all of us will agree 2 liters won't be enough in cardiogenic shock or whatever, but even impeller 2.5 or 3.5 won't be enough for in a cardiogenic shock. You're talking about 5.5, that's a 23 French device. And that's it. Thank you very much.
Thank you. Thank you for saving 1.5 minutes for us.
Well, I've been asked to do that.
So we open the floor for discussion and from the panelists.
Any question?
دكتور محمد مطر.
Any question?
دكتور محمد مطر.
Do you have the mind? How about the acute kidney injury? Right,
if you look at the
That's okay.
during the registry with 174 cases, on iVAC they reported no kidney injury whatsoever, versus 11%, 12% in impeller.
You said 6.7.
No.
0?
Oh, sorry, 6.7 report hemolysis 0%, but 6.7. I mean, those are big devices, even in balloon pump.
How many French?
80.
18, which is more than Impella. Impella 13.
Impella CP is 14 French. CP, but 5.5 is 23 French.
How about the vascular complication? Because all the, with the support device, as we talked about with Sam in the morning session, about the compromise between what you gain from the support device and what you lose by the access morbidity and mortality.
Absolutely, but right, this is what you do. I mean, if you're going to attempt those cases with no support, you're going to kill the patient. It's the rejection fraction 12%. You have to a trade-off at some point. And as far as, I always got no problem as far as the patient is well consented and he knows exactly what we're talking about. And it's not a safe procedure what we are doing. And most of those are actually kidney injuries. They are just with reverse. And this guy, we had a baseline of creatinine of 1.6, mainly due to all his medications. But again, till now, he's still on 1.6, 18 months later.
Please.
Dr. Samir, you have a
Dr.
question?
Mohammed.
You have a question?
Oh, thank you very much, Dr. Amr. My question focusing on the mechanical circulatory support. As we know, there is significant downgrade recommendation by the guideline.
Go ahead. We are hearing you.
It's okay. So there is a downgrade regulation or recommendation by the European guideline to the class 3 routine unless there is mechanical complication. So my question for you, in case of the chronic coronary syndrome, what's the indication of mechanical circulatory support, and is there any superiority of one device over other, like intra-aortic balloon, ECMO, or ampulla? And thank you very much.
In which cases?
Which acute coronary syndrome?
No, acute coronary syndrome, there is no indication routinely unless there is mechanical complication. But my question for you, in case of the chronic coronary syndrome, is there any trial, any studies support the superiority of the one device over other? And secondly, what's the indication for mechanical circulatory support in patient with chronic coronary syndrome underwent PCI?
I think if you're going to go into the recommendation, when you go into those trials, it's like you in ICU. You throw everything you've got. You're not going to randomize a patient while you've got something you may support that patient. All of us know that the intra-aortic balloon pump is useless. I mean, we've been using it for the last donkey's years. I'm not sure how many, 20, 25 years. But we know that the best scenario is probably will give you less than 700 mils of cardiac output. And there are some controversy whether if you put intra-aortic balloon pump before in front or you do it during the procedure, you may affect the outcome. But I mean, we've been using intra-aortic balloon pump with no real benefit for patients, in my opinion. If you're going to talk about cardiogenic shock in acute coronary syndrome, I think even Impella is not enough. You start talking about ECMO Impella on those patients. If you're talking about acute coronary syndrome, significant drop in LV, the guidelines all tend to say if you got LV function less than 35% with a high-risk PCI, three-vessel disease of left main, you should consider a supporting device.
Thank you very much. But sorry, Doctor, follow the PROTECT 2 trial, show that there is no any difference between the intra-aortic balloon versus ampulla regard 30 days mortality. Intra-aortic balloon very popular, very commonly used, and the ampulla is not almost always available. Secondly, I want to add some points that's very practical for all of us in case of chronic coronary syndrome, when should be followed a very interesting algorithm, which is PCI protected algorithm, and look for the score. If the score less than 2, there is no indication, 3 possible, and more than 4 strongly recommend. And this based on the LV function, mitral regurgitation, present absent, acute coronary syndrome versus chronic.
I mean, if you're going to talk about the PROTECT 2 trials, and if you're going to look at the 30-day mortality, but if you look slightly longer, it's 11% versus 20%, so you're talking about 9%. difference.
So by saying this,
So it's not only
I
1
think
month we're talking about. We're talking to talk about this patient's life for longer.
we will take one question because we postpone you many times.
Samir, short
Okay.
question. Small question and small answer.
Okay, thank you very much. I'm just wondering, for those kind of patients who are non-compliant to treatment with diffuse coronary artery disease and reduced ejection fraction, using all these stuffs and materials, comparing to just medical treatment, is it cost effective?
I mean, I take your point, but he's a typical Jordanian patient who doesn't want medications. And he's still now, he keeps on and off, taking off his Entresto and his Jardians. But the aim of this procedure was not to prolong his life. I'm not sure that his ejection fraction went from 12, now it's hovering around 25. So it's actually, I haven't gained a lot in his LV function. But the aim of this procedure is to give him a bit of quality of life, which we gave. Now he goes to the supermarkets, he goes to the mosque, so he's getting slight good.
Maybe because he is more compliant, just.
Sorry?
Maybe because he is more compliant to treatment.
No, he's still non-compliant.
Guys, if you are not hungry, you can stay. If you are hungry, go to the lunch.
شكرا جزيلا، شكرا جزيلا، بارك الله فيك. على الغداء.
اهلا وسهلا بكم.